So our topic in this lecture will cover the Duchenne muscle dystrophy. We're gonna have a case presentation and novel. We're gonna talk about novel therapeutic approach for Duchenne muscle dystrophy. Okay. Here we have our patient, which is called Hassan. He is a male patient, 11 years old, diagnosed as Duchenne muscle dystrophy, and presented to us on a wheelchair for follow-up. First of all, you have to take the present history, the history of present illness. The condition started since Hassan was 3 years old by muscle weakness with gradual onset and progressive course. The patient expressed bilateral symmetrical muscle weakness in the lower limbs that were noticed by secondary inability to climb stairs at the age of 4. The gene of muscle dystrophy is present since birth, but the symptoms do not appear except in early childhood. So the symptoms does not appear at birth. This was followed by difficulty in running and standing up, repeated falls during walking. Then he walked in his toe. Toe walking here in Duchenne muscle dystrophy is done by feet apart while to keep the balance during walking because the muscles are already weak. So we're going to talk about the pattern of the weakness. The weakness is proximal and is less in the upper limb muscle because our patient can use his hand and can hold things that are not heavy, which means that the gross motor function are affected in Duchenne muscle dystrophy while the fine motors are less affected. Our patient sought medical advice and was diagnosed as Duchenne muscle dystrophy, and he lost his ambulation at the age of 10. Usually, the patient of Duchenne muscle dystrophy become non-ambulatory at the age of 8 to 10. Okay. Here, at this point, you have to clarify the type of muscle weakness to differentiate between the muscle dystrophy of Duchenne and the other types of myopathy or muscle weakness. So here, in our patient, the weakness showed no journal variation. There is no ptosis. There is no weakness in the face muscle and no problems in swallowing or talking. Also, there are no attacks of seizures, no sensory loss or sphincter control problems. At this point, you have to ask about the mental and the intellectual state of the patient because the mutation in dystrophin protein, which is present in muscle, is present also in brain and centers that control the mentality and the social behavior effect. Okay, so here in our patient, the patient stopped to go to school since he was a wheelchair dependent, and he showed no mental regression or learning disabilities before. The intellectual affection is present in 1/3 of the patient of Duchenne muscle dystrophy. Also, in the history, you have to ask about the complication of the disease. The main complication are weakness of the heart muscle, weakness of respiratory muscle, and bone and spine complication. Regarding the muscle of the heart, you have to ask about symptoms of like tiredness, dyspnea, irregular heartbeats, or swollen leg. They are all absent in our patient here, and you have to ask about the symptom of heart failure or cardiomyopathy. Unfortunately, cardiomyopathy happens in 1/3. It presents at the age of 8 in Duchenne muscle dystrophy, and it is present in 1/3 of patients at the age of 14, and in 100% of the patient at the age of 18. Cardiomyopathy leads to death. Why? Because the heart muscle become very weak and the walls of the heart are very thin and they are unable to pump blood. So death happens usually in Duchenne muscle dystrophy due to cardiomyopathy, which is of the dilated type. The other complication is the chest problem. You have to ask about symptoms of chest disease, repeated chest infection, repeated hospital admission, or respiratory problems or need for ventilation. Here in our patient, this history is negative. There is no history of respiratory problems or repeated hospital admission for chest infection. Also, you have to ask about the bone and spine problems. Here in our patient, there is no history of osteoporosis, scoliosis, or repeated bone fracture. To complete our history, you have to ask about history of other system. There is no hepatomegaly, no constipation, or no symptoms of other system involved. Developmental history, you're gonna ask about the developmental and history and the gross and fine motor developmental history. Hassan made his support at the age of 2 months. He stood without support at 12 months and walked at the age of 18 months. You can see here there is developmental delay in this patient. All the patients of Duchenne muscle dystrophy, they show developmental delay before the symptoms begin. Also, he climbed stairs at the age of 2.5 years. He could make a tower of 3 at the age of 18 months. The mentality and speech here, as we said before, the mentality in our patient is not affected, so he recognized his mother at the age of 6, which is normal, and said the sentence of 4 words at the age of 3.5 years. For the vaccination history, Hassan took his vaccination as scheduled, and last vaccine was 2 years ago. It was the influenza vaccine. The family history, there was no similar condition in the family, which means that it's immune mutation. There is no parent positive consanguinity history. The past history here, Hassan sought medical advice since he was 5 years old and made several investigations and received medical treatment. Here, the main medical treatment here was steroid. This is not only palliative treatment for Duchenne muscle dystrophy patient. Hassan received a dose of 0.7 milligram per kg per day, and the regimen of steroid, we have 2 ways of taking steroid, either intermittent or continuous. Here, Hassan took 1 tablet of steroid per day in the first 10 days of the month and 20 days of, which means intermittent course. But his mother stopped giving him treatment 6 months ago because he gained weight, and this is one of the complications of the steroid therapy. And we're gonna have to manage this and give him more convenient way of taking the steroid or change the type of steroid. When we talk about Duchenne muscle dystrophy in general, what is the diagnostic test here? First of all, you have to measure the blood CK. The blood CK is not specific for Duchenne muscle dystrophy, but here it shows an increase of 10 to 100 times the normal level of any patient. The diagnostic test could be genetic study or muscle biopsy. Genetic study, we have to take a sample of blood to test for Duchenne myopathy gene, while muscle biopsy, you have to examine the muscle fiber for Duchenne protein. Also, the muscle biopsy can differentiate between 2 types of dystrophy, Duchenne muscle dystrophy and Becker's, which is a lighter form of Duchenne muscle dystrophy. Okay. The other test that could be done in case of Duchenne muscle biopsy is the liver transaminase. ALT and AST are enzymes produced by the liver and the muscles, and they are highly increased in Duchenne muscle biopsy. So as a rule, in any male patient, before going to liver biopsy, when there is increased transaminase, you have to rule out Duchenne muscle dystrophy. What are the follow-up tests and the investigation that should be done in this case? First of all, you have to make routine ECG and echo to discover heart failure and cardiomyopathy, pulmonary function test to keep respiratory function well as possible. You have to make bone and spine X-ray when there is deformities or fractures. Also, you have to make investigation to look for the drug complication like the weight gain, to monitor the growth rate because it is inhibited here or slow when taking steroid. Also, you have to monitor blood glucose and the blood pressure of the patient. Regarding the general examination, you have to examine the patient from head to toe. Also, you have to examine the patient to look for drug complication like cotinoid phase, like weight. As we said, there is weight gain. There is also impaired fat glucose metabolism, fluid retention, hypertension, osteoporosis, and cataract. Regarding the neurological examination, you have to make full neurological examination, especially the motor system. You have to compare between right and left as usual, and to make muscle inspection and palpation, and to make all the tests needed, and to make sensory examination and back examination and bone examination to look for scoliosis, for bone deformities or contracture of tendon Achilles, which is a permanent finding in this patient due to loss of the stretching ability of the muscle. Here, to summarize, the positive finding in our patient here, we found that there is hypotonia and decreased muscle power to the grade 0. And this hypotonia is at the proximal muscle, which is the muscle near the trunk and the hip and shoulders. And this is in contrary to neuropathy, because in neuropathy, the muscle weakness is distal and not proximal. Also, as a positive finding, we found that weakness is more in the lower limb than the upper limb. So, and there is relative pseudohypertrophy, which means that the calf muscle become bulky, but they are weak. Why? Because after death of the muscle fibers, they are replaced by connective tissue, and they give the bulky appearance, but they are non-functioning. Here, Gower test couldn't be assessed because Hassan is non-ambulatory. He's on wheelchair, so we cannot assess Gower test. Gower test is done to assess the weakness of the hip muscle, but here he couldn't be assessed. Now we can have an overview on Duchenne muscle dystrophy. I'm going to talk about the incidence of this disease. It is one every 3,500 male births, and it is due to lethal mutation in the dystrophin gene in X chromosome. As you see, this is the X chromosome, and this is the dystrophin gene. The mode of inheritance, Duchenne muscle dystrophy spreads as a recessive X-linked disorder that affects both, which means that females are carriers because they have mutation on only one chromosome. Now we're going to talk about the management, how to manage a case of Duchenne muscle dystrophy. Unfortunately, there is no cure for Duchenne muscle dystrophy. The aim of treatment is mainly to control symptoms and to improve the quality of life and to monitor the patient health carefully. So you have to make a multidisciplinary management system to manage the symptoms for the treatment of Duchenne muscle dystrophy. The medical management here, as I said before, steroids are the only palliative treatment for Duchenne muscle dystrophy, but they have many side effects. The benefit of steroids, they increase the muscle strength and increase the function of the muscle and delay the patient from becoming wheelchair. Also, as a medical treatment, we may use beta blockers when there is heart failure. You have to treat the chest infection by antibiotics or bronchodilators. Have to treat the constipation because if there is weakness of the GIT abdominal muscle, so the patient will suffer from constipation. Also, you have to give the patient mobility aids like walker or motorized wheelchair if needed. A physiotherapy is very important here for the patient. Also, respiratory aids, he may need respiratory aids or artificial ventilation. Counseling and emotional support is very, very important for the patient and his family. Also, you have to detect the carrier and to make antenatal diagnosis for carrier mothers. Surgical treatment could be needed, for example, insertion of feeding tube in case of weakness of muscles of pharynx. Spinal surgery, here the surgery to correct scoliosis, and scoliosis will improve the respiration and improve the general appearance. Also, foot surgery and surgical release of tendon Achilles because of contractures out, as we mentioned before. Now we're gonna talk about novel therapeutic approach and new hope for this patient. But before mentioning this method of treatment, we have to talk about the Duchenne protein. Okay, the Duchenne protein here is present in the membrane that surrounds the muscle fiber. It has a role to protect the muscle from damage during contraction. This is the role of Duchenne protein. In the absence of Duchenne proteins, as in this disease, the calcium does not enter the cell and water will enter the mitochondria and the cell will be burst. This will make necrosis of muscle fibers and the fibers are replaced by connective tissue which will give the picture of pseudo-hypertrophy as we mentioned before. We have to mention that small amount of dystrophin protein are present in the nerve cell and the centers that are responsible for learning, memory, and emotion. That's why we have to ask in the history about intellectual disabilities and behavior change. So dystrophin is present in muscle and in parts of the brain. Now we're gonna talk about genes and mutation, what will happen when there is mutation in the Duchenne muscle dystrophy disease. First of all, you have to know that the gene is a part of DNA that is responsible to give instruction for production of specific protein. Genes are divided into parts called exon and introns. The introns are cut during production of protein and they leave only the exon, and the exon they will code for the protein. Let's have a look about the dystrophin gene or the gene here in dystrophin muscle dystrophy. This is our largest genes here, which is present as I mentioned before in X chromosome. Our largest gene here, the dystrophin gene, it contains 79 exons, which are pieced together or joined together as you see here. What will happen when there is mutation in this gene? Okay, whenever there is the mutation here in the genes, there is an exon skipping or deleted, okay, or many exons. This will interfere with the rest of the gene being pieced together and the result in defective or non-functioning Duchenne protein, as you see here. This exon is skipping. As you see here, this is the normal dystrophin gene, and this is defective dystrophin due to gene mutation. What are the types of gene mutation in dystrophin muscle dystrophy? We have exon deletion, which accounts for 70% of patients, and point mutation, about 30% of patients. Let's have an example. This is here the deletion of exon 49 and 50, which result in defective dystrophin gene. This is one of type of mutation in this disease. What are the novel therapies for Duchenne muscle dystrophy? Here, some novel method like gene therapy, stem cell therapy and dystrophin restoration approach, which is reached the clinical trials. Okay, and this is the promising or new hope for this patient. Also, there is other method like stop codon suppression agent, which allows the continuation of production of and translation of protein, and they are used in nonsense mutation. This novel method faced many challenges. First of all, the appropriate clinical trial design, adequate systemic delivery, and mutation specificity of some therapies, safety and tolerability, and host immune response. This is the challenge that are facing this new method. We're gonna talk in details about exon skipping therapy for Duchenne muscle dystrophy. The principle of exon skipping here is to encourage the cellular mechanism to skip over an exon. Can you see here? This is exon which is deleted. So we have to encourage the production of protein through skipping this exon. We're gonna put a small piece, a patch or plaster called antisense oligonucleotide over this gene, and they're gonna translate the whole protein and make the production of protein and skipping this missing part through a molecular plaster or a molecular patch. Exon 51 skipping trials was successful in restoring the dystrophin protein in experimental rates and will be applicable for about 13% of boys in Duchenne muscular dystrophy. Once this technology has been established and effective, so it will be possible to design other patch and to treat other types of mutation. And this is the experimental trials in rats, which shows exon 51 deletion. And this is the molecular patch and plaster to skip this deletion. And this is recovery of dystrophin. Lastly, the dystrophin is produced as normal in rats. Now we are in the stage of clinical trials for this example. The conclusion, it is believed that skipping one or two exons would be able to treat around 83% of the genetic errors causing Duchenne muscular dystrophy and stop the symptoms. There is much hope that this modifying therapy becoming available in the near future to help the patient of Duchenne muscular dystrophy. That's all for today, and thank you for listening.